Hello, everyone. For those who haven't joined us before, my name is Mita Kessler, and as Operations Manager for Capstone Performance Systems, I'm very glad to welcome each of you to the fifth and final session of our ICD-10 webinar series. Also, a quick reminder that these webinars are recorded and available for download on our website, www.capstoneperformancesystems.com, by navigating to the ICD-10 Support tab on the top menu. The PDF handout of today's slides is also available on the Start Meeting event webpage. Capstone is pleased to sponsor this series for our PACE clients, friends, and the larger PACE community. We have been helping PACE organizations improve documentation, compliance, and revenues for over 10 years and have had the pleasure of working in over 2/3 of the programs in the U.S. We've learned a lot over these years and hope to share some of that knowledge with you today. Capstone also offers additional training and support to our clients, so feel free to contact us if you have any questions about our services. At the end of this presentation, we will take time to answer any questions. At that time, if you have a question, please press *6 on your phone to be entered into the question queue. I now want to introduce Angie Ladd, RN and Certified Coder, who is head of our coding department here at Capstone.
Good afternoon, everyone, and welcome to Webinar 5, Documenting and Coding for Neoplasms, Cerebrovascular Disease, Dementia, and Major Depression. Please be advised, today is the last installment of the ICD-10 Documentation and Coding Webinar Series. All of the recordings and handouts are available on our website under the ICD-10 Preparation tab. Presenting with me today is Dr. Mike Brett, Chief Medical Officer for Capstone Performance Systems. I am sure many of you have had the pleasure of speaking to or working with Mike, and it is my pleasure to welcome him in presenting with me today. As always, we will hold a question and answer session at the end of today's webinar. And again, just remember to press *6 to be entered into the queue. And now, without further ado, I present to you Webinar 5. So the objectives for today are to give you a quick summary of Webinar 4. We are going to review Chapter 2, which contains neoplasms. We are going to review Chapter 5, which is the Mental and Behavioral Disorders chapter. We are going to also review a section of Chapter 9, which diseases of the circulatory system, specifically reviewing cerebrovascular disease, which obviously will include cerebrovascular accident. We are going to also review the documentation and coding for neoplasms, dementia, CVA, and major depression as well today. All right, so from last week, Chapter 10, the respiratory system. There are more codes for COPD. As you remember, in ICD-9, COPD itself had one code, 496. Now the J44 code is COPD, and included in that is your chronic obstructive bronchitis and your chronic obstructive asthma. And if you remember from ICD-9, which I'm sure you do, chronic obstructive bronchitis was a separate code, as was chronic obstructive asthma. Now it is all included in the J44 category. There is an additional code for tobacco use and exposure, and documentation of chronic obstructive asthma or asthma with COPD. You must remember to do either of these for HCC 111. So again, document chronic obstructive asthma or asthma with COPD. Asthma has more specificity. You now have the option for mild and mild persistent, moderate persistent, and severe persistent asthma choices. And obviously, too, as we talked about last week, when you're stating chronic obstructive asthma, you're using the J44, and you're also going to add in the type of asthma, which is the J45 category. Respiratory failure, again, there is little change from ICD-9. One of the differences is it now has its own category. It's the J96 category. It is for respiratory failure alone. It is no longer in with other respiratory disorders. It does now include an additional fifth character for with hypoxia, which it would be assigned a fifth character of 1, or with hypercapnia, the fifth character, additional character of number 2. The same documentation requirements still exist. You must meet the criteria for support of a chronic respiratory failure diagnosis, which is oxygen greater than 15 liters. I'm sorry, yes, greater than 15 liters. I didn't mean to. Greater than 15 hours a day, and they must be hypoxic at rest or with very little activity. Critical care nurse, 15 liters. Sorry about that. Okay, so Chapter 12, diseases of the skin and subcutaneous system. Pressure ulcers are now combination codes. You have your pressure and non-pressure ulcers. And again, these are combination codes. And remember, they were L89 and L97. It now includes the stage and the site or area in the code. So it is a pressure ulcer, stage 1, and then the area, right elbow or wherever it is. It does include, as it did in ICD-9, it does include descriptive terms to identify the stage clinically and notes healing ulcers. So as I said, both are present in ICD-9, but it's just noteworthy to say that this is continuing. And if it is by description, I suppose you could assign a code by description. And again, healing ulcers, they were present in 9. They're still documented, they're still coded this way in ICD-10. But they should be documented as healing ulcers, so you never upstage. So again, if it is a stage 3, if it's originally documented as a stage 3, as it continues to heal, it will continue to be documented as a stage 3, but it will be documented a healing stage 3 ulcer. And also, descriptive terms for pressure and non-pressure ulcers are not the same. So make sure that the pressure ulcers, that is a staging, and non-pressure ulcer is basically a depth and appearance description. Review of Chapter 4 quickly. There are 3 different categories of codes for the degrees of malnutrition. In ICD-9, it was 1 code. It was the 263 category. And in ICD-10, you have E44 for protein calorie malnutrition. You can choose your degrees, mild or moderate, and you note the difference in the 4th character of a 0 or a 1 for each. E46 is protein calorie malnutrition unspecified. That is the only code in that category. And then you have E43, severe protein calorie malnutrition. And again, I caution you using that unless your documentation is quite specific. Okay, any questions about Webinar 4? And again, all of the slides and the recordings are available on our website, www.capstoneperformancesystems.com, under the ICD-10 preparation tab. And you will notice that if you've checked before for the handouts, they were not on the website. They will be now, and especially after this one today, they will all 1 through 4 handouts will be on this under the ICD-10 preparation. Okay, so we're going to get started. Chapter 2, Neoplasms. It's similar to ICD-9 in the way it's laid out, and essentially the way you code it. There's basically what we're looking in difference here is a lot more specificity. So the Neoplasms table still exists. The difference in ICD-10, it is now found at the end of the alphabetic index, which really is, well, I suppose if you're coding it, then you would need to know where it is, but I would say that's more for the coders. There is more granularity and detail in this chapter, and that is based on sex, male or female, laterality, site-specific body part, and now we have a malignancy of overlapping sites. So there's a coding guideline. This is new. It is for primary malignant neoplasms of overlapping sites. What it says is that if you have malignancy overlapping 2 or more contiguous sites classified to the subcategory or code, there is actually and you see this below, there is actually a code for overlapping lesions. So the 2 examples are listed there. Malignant neoplasm of overlapping sites of the right female breast is C50.811. And malignant neoplasm of overlapping sites of the left male breast, I just threw that in there so you can see the difference in male-female, is C50.822. So if you remember in ICD-9, you had malignant neoplasm of the breast, and that was it. It was category 174, and there was no distinction between male and female. So now there is. So having said that, I don't see it often, but I have seen it before. So if it is of the male breast, you obviously must state that. You must document that. Great. Okay. So here are some examples of the increase in specificity of the malignant neoplasms. We are going to use category C50, malignant neoplasm of the breast. So in ICD-9, there were 11 codes. In ICD-10, there are 54 codes. And again, that is attributed to sex, site, and laterality. There is an additional code for estrogen receptor status. You have your estrogen receptor positive and your estrogen receptor negative, and then a Z17.0 and Z17.1. So your documentation needs to be specific, and what I mean by that is, other than what I said about, male, female, and, side and site, if it's primary, it must be documented as primary, which is the C50 category. Under that, you also have it of the mastectomy site, which is D44.501. You have for in situ, which is D05. Whatever. And then you also have the metastatic, which is the C79.81. And we're going to talk about that next. So what I want to note here is, and this really is actually an ICD-9 anyway, but I want to make sure I note it to you all. Metastasis documentation has to be clear. When you document metastatic breast cancer, it can be a little confusing. I know it is for me. When I see, and that goes for any cancer, when I see something documented as metastatic something cancer, I have, and there's no further documentation, I'm wondering always, is it metastasized to the breast, or is it breast metastasized to somewhere else? So you must document if the breast cancer is the primary malignancy, or if it has metastasized from another primary site. And again, as I said, this is the same. This goes for all or any metastatic cancers. You also have your history of neoplasms code. This is the Z85 category. This is the same as an ICD-9. It is just further broken down into area and organ. And again, as I said, it's the same. You'll have history of breast cancer, history of prostate cancer, history of kidney, things like that. It's very similar to ICD-9. Okay. So what I'm talking about now are the guidelines for coding current malignancy versus personal history of. According to ICD-9, when a primary malignancy has been excised but further treatment is directed to the site, the primary malignancy code should be used. And examples of excise would be additional surgery, or if it had chemo or radiation. If you are still treating it, so if they're on Lupron or Arimidex or something like that, if you're still treating it, you can still use the primary malignancy code. If there is no treatment to an excised or eradicated malignancy and no evidence of malignancy exists, you then must use the history code Z85, and then it follows for whatever area of the malignancy. Okay, so we're going to talk about leukemia, multiple myeloma, and malignant plasma cell neoplasms. What I want to talk about here is the remission versus history, because I think sometimes this can get confusing. So categories C90 and C91 through C95, that encompasses the leukemia, multiple myeloma, and malignant plasma cell neoplasms. It includes codes for remission, which would be the 5th digit. So here are your choices. You have, is the leukemia, or other, whatever's listed there, is the leukemia, has it not having achieved remission, is it in remission, or is it in relapse? So this section, this category of malignant neoplasms is a little bit different because you must document if it is one of the three. So then obviously your fifth digit is your 0 for not having achieved remission, 1 for in remission, or 2 for in relapse. You must document clearly remission versus history of. Because there is a code for that. So, we would talk about remission, and then we talk about history. So history of leukemia and other malignant neoplasms of lymphoid or hematopoietic and related tissues have their own codes. Z85.6 is the history of leukemia, and Z85.79 is the history of other malignant neoplasms of lymphoid tissue. So here's the comparison as to why it's important, remission versus history. Okay, lymphomas. I want to mention this because I think sometimes people don't realize this. Lymphomas are coded even when it is documented in remission. You would assign the appropriate code from any of the categories in CD1 through C96. This did not change. This is the same as it was in ICD-9, and your coders will know this. The AHA coding clinic states, lymphoma patients who are in remission are still considered to have lymphoma and should be assigned the appropriate code, and as I said, from whatever the categories are. Okay. So here's a documentation example. 57-year-old female with breast cancer of the left upper outer quadrant, now spread to the lung, left lower lobe. The assessment plan, breast cancer, left upper outer quadrant, is estrogen receptor negative with metastasis to the lung, left lower lobe. So here is a perfect example of how you should document that. We have metastasis to the lung. So then we know, so obviously the plan is continue with current treatment and oncology follow-up. So now from this we know the code for breast cancer is C50.412, and the metastasis to the lung, or you can term it as the secondary malignancy, is C78.02, and then your estrogen receptor negative status is Z17.1. So this is just a good example of being clear on primary and secondary malignancies. Okay, cerebrovascular disease. These are categories I-60 to I-69. There is an instruction at the beginning of the category for cerebrovascular diseases to use an additional code to identify any alcohol abuse or dependence, which is your F10 category, which Mike will talk about, and your tobacco use and exposure also. The codes are expanded for acute cerebral infarction. So right now we're just going to talk about acute. You now are going to need to document the cause. Is it embolytic, thrombolytic? Is it unspecified? Or is it occlusion or stenosis resulting in infarction? You need to talk about the artery involved, pre-cerebral or cerebral, and laterality. So no longer can we capture occlusion and stenosis of an artery with or without infarction with the fifth digit. So if you remember from ICD-9, you could have occlusion and stenosis of the carotid artery with and without infarction, and it would be the 433 category. The fifth digit of a 0 or a 1 would designate with or without infarction. Now there are two different categories. So I-65 is occlusion and stenosis of pre-cerebral arteries without infarction. And you see there I-65.0 to 0.9 is without infarction. This is formerly 433.10. And then you go to the I-63 category, which is cerebral infarction. It's I-63, and then there are 3 characters after that. This is for carotid arteries only. And this is forward mapping, or backward mapping rather, to 433.11, the former category. Pardon me for ICD-9. Okay. Some of the other categories in the cerebrovascular disease chapter are I-60, non-traumatic subarachnoid hemorrhage, I-61, non-traumatic intracerebral, I-62, non-traumatic intracranial hemorrhages, and I-63 again, cerebral infarction, specifying the cause, the site, and the laterality. Most likely, you won't have to document too much for acute cerebral infarction because most of the time these are not happening in the PACE center. Not that it can't and not that it hasn't, but most time you are going to deal with your sequela, which we'll get to. Okay. To continue on the categories from I-60 to I-69, I-65, occlusion and stenosis of the precerebral arteries without infarction, which we discussed. I-66, the difference here is it is of the cerebral arteries without infarction. I-67 contains other cerebral vascular diseases, which are cerebral aneurysm and your cerebral atherosclerosis. It's hard to say. And then I-68, cerebral vascular disorders classified elsewhere, which contains such conditions such as cerebral arteritis. Okay. Now on to everyone's favorite chapter, late effects of cerebral vascular disease. It is not termed that anymore. The I-69 chapter is now termed sequela of cerebral vascular disease, which formerly was 438. Now it's I-69. So we're plain bingo. Okay. Used to indicate conditions from I-60 to I-67 as the cause of the sequela. So all of the conditions, all of the categories that I just reviewed with you that are in this cerebrovascular disease, if there is a sequela from any of those categories, then you can use the sequela of cerebrovascular disease code, I-69. Again, it is similar to the category 438 in I-69. The difference is the sequela are more detailed in the I-69 category. They are also separated into sequela for each cerebral vascular disease. So, in other words, there are, sequela of intracranial hemorrhage, the sequela of subdural hemorrhage. So it's not just, this category is not, the sequela category is not just for late effects of a stroke. It is for any cerebrovascular disease that fits into the I-60 to I-67 category. Okay. You do have I-69.3, which is the category we're going to talk about, sequela of cerebral infarction, i.e. CVA or stroke. So, again, the categories are similar to I-9, but they have more specificity, which we're going to see soon. Okay. The biggest change in ICD-10, because the I-69.3 category is very similar to the 438 in terms of the late effect of stroke. The difference is right here. The biggest change is with the monoplegia, the hemiplegia, and the other paralytic syndromes, which is I-69.331 to I-69.369. The difference is this. You have your laterality specification. So it used to say dominant, non-dominant, and unspecified. Now it's right dominant, left dominant, right non-dominant, and left non-dominant. I will tell you that the default code for unspecified affected side is as follows. Right affected side, it's considered dominant. That is the default code. If it's a left affected side, the default would be non-dominant. And if your patient is ambidextrous, it is the default code is dominant. Okay, biggest change there. Other sequela of cerebral infarction, I-69.390. This is where your alterations in sensation and alterations in visual disturbances come in. In ICD-9, they were two categories. So you had your alterations in sensation was a code. I'm sorry, not category, code. Alterations in sensation was a code, and visual disturbances as a late effect of CVA was another code. Now they're one code. And again, it's I-69.398. You still need to add an additional code to identify the sequela. So in terms of history of TIA, CVA without residual effects, you still have this in ICD-9. It was V12.54. ICD-10, it is Z86.73. You cannot code both I-69 and Z86.73 except when there is both a late effect from a previous and history of, if the patient has a current cerebrovascular disease, and then deficits from the previous. So if they've had a stroke and they have no residual deficits, then you would code the Z86.73. In a couple years down the road, they have another stroke, and now they have aphasia. That is the only time you can use both codes. You cannot code both a history of and the late effect when there's only one cerebrovascular disease. So if they have one stroke and there's no deficit, you can only use Z86. I see it many times is that they say V12.54, and then 2 lines down it'll say expressive aphasia due to CVA. You can't do that. Only when you have had a previous with none, or vice versa. Either way, you have to have both. Codes from the I-69 category should not be assigned if there are no neurologic deficits present. So as I said, if they have no deficits, you have to use the history of code, because that's the code that states no deficits. And if there are, then you would use the code from I-69. Okay, so I am now going to turn the floor to Dr. Brett.
Well, thank you, Angie. Angie's been having these parties every week, and it took the last party before I got an invitation, but I do appreciate that. What I'd like to do is talk a little bit about both dementia and coding in dementia, and also with depression. The first thing I'd like to point out is that we have really 2 perfect storms going on at the same time, and that is we're all starting to use ICD-10 in about a month from now. But what came out last year also from the American Psychiatric Association was the new DSM-5 criteria. And so we're speaking 2 different languages coming at us at the same time. Though I thought I'd make a few comments about DSM-5, please understand that ICD-10 has been around for a long time. It's just the United States is late coming to using it. So that the language that's used with ICD-10 really uses DSM-4 language. But given the fact that 5 is out there and you're going to be hearing these terms, I thought I should just make just a few notes about that. In DSM-5, the word dementia is going to be replaced, or is replaced, with neurocognitive impairment. And they did this. They were trying to be sensitive to the fact that, 20, 30 years ago, there was a lot of young folks coming down, unfortunately, with HIV dementia, and just really didn't like the label of dementia being associated with that. So they've come up with this term that's called neurocognitive impairment. Now, given the fact that's the new terminology, it's been well accepted that dementia is here and will be used by, I'm sure, all of us for many years to come. But I think in time we'll start to see more use of this word neurocognitive impairment. And they simply will have it defined as either being minor or major, with the degree of standard deviations beyond the norm in neuropsychiatric testing. Next slide. So again, we can have major, minor neurocognitive impairment, but we all know these different neurocognitive domains. Dementia is really amnesia, aphasia, apraxia, agnosia, executive dysfunction, if you will, troubles with visual spatial. And in DSM-4, they said you had to have forgetfulness. You had to have amnesia plus something else. In DSM-5, they were saying you just need to have really not 1 or more, but 2 or more impairments in cognitive domains. So it doesn't necessarily have to mean that the participant is having memory loss. And they did that because if you think about frontal lobe dementias, if you think about those conditions, many times you can have significant cognitive loss, but yet you still have relatively good memory late into the course of that illness. So once again, ICD-10 is still going to be using the terminology dementia moving forward, but be aware of the fact that you're going to see these new terms, neurocognitive impairment, coming about. Next slide. So again, I think most folks understand amnesia, apraxia, those terms. Executive functioning is planning, stopping, controlling, regulating. You can see these kind of terms. I like to think about the person who's baking a cake and all the steps they have to go through and plan from the time they start mixing the dry ingredients and the wet ingredients before the cake goes in the oven. That's all executive functioning. And when you do those kind of tasks, that requires a lot of IADLs. And so when you start to see impairment in executive functioning, you're going to see impairment in IADLs. And I always like to point out when I'm going to visit our clients is that the guru who sits at the table, the IDT table, who knows more about IADLs, is typically occupational therapy, and they should be aware of the fact that when they see impairments in IADLs, to at least bring that to the team. And could there be some early cognitive loss going on as well? Next slide. So when we go to actually code dementia, there are two different chapters where you find dementia codes. You find them in the mental disorders and you find them in the neurologic disorders. And we like to think about coding dementia, thinking about it in terms of genotype and phenotype. And genotype is if you actually could see what was wrong with the person, if you could get a little brain biopsy, that's what you would code. And those are the neurologic disorders. Phenotype more is more of a descriptive term as to what you're actually seeing, and that's where we see that word dementia come into place. The important thing is that we want to be able to code from both, and the coding guidelines say that next slide if you would. The coding guidelines say that what you should do is always start and code from the neurologic disorders first. So is it Parkinson's disease, Alzheimer's disease, Lewy body dementia, what have you? Code there first if you know what it is. Now, many times you won't because perhaps the person is too far demented to be able to make that determination. But if you can, code from the neurologic disorders first, and then code from the mental disorders. And so once again, here we see it is listed with dementias. And so it's genotype, if you will, and phenotype. The reason to code both is particularly that if we want to be able to pick up complicated dementia, or the HCC that is complicated dementia, which is a higher risk factor than the uncomplicated dementia, we can only pick those up from the mental disorder codes. Next slide. So we know that with ICD-9, there were different categories. And again, these are the mental disorders. There was pre-senile, senile dementia, vascular dementia. And in times past, or at least in the next 4 weeks, before we go to ICD-10, there were 4 conditions that made dementia complicated versus uncomplicated, and that was delirium, delusions, and depression. So we can see that all these categories with the pre-senile, senile, and vascular dementia, with delirium, delusions, depression, that used to all bring complicated dementia HCC, but in ICD-10 it won't. Next slide. Here is what the codes look like from the mental disorders in ICD-10. There is vascular dementia, the FO1.5. Then there's dementia in diseases classified elsewhere, FO2.8. So if you actually had the genotype, if you listed that it was Alzheimer's disease, then you would come and code from the FO2.8 because you defined that other disease. And then the unspecified dementia, which is the FO3.9. But here now, once again, for each of those codes, you need to code with or without behaviors, because this is, again, where the complicated dementias come. We get them only with behaviors now, but once again, we have to, whenever we code, state whether the dementia is with or without behaviors. Lastly, there is a code FO5, which is delirium due to known physiologic conditions, which I would think would include dementia. And so certainly if someone's having delirium, you could code that as well. I just point out that that does not risk adjust. That's a complete code and will describe your participant, but that does not lead to complicated dementia. Next. So, again, as I mentioned, whenever the proper way to code from the coding guidelines is to code from the neurologic disorders first and then from the mental disorders. So in ICD-9, we had complicated dementia with delirium, depression, delusions, and behaviors, but in ICD-10, complicated dementia will include the behavior disturbances only. Next. So what are those behaviors? Well, I mean, there's a lot of behaviors our participants have, but to really, I think, to be coding them correctly with the previous terminology, it should be behaviors that are endangering themselves or others. So resisting care, well, perhaps if it was really severe, certainly wandering or pacing, kicking, screaming, hitting, catastrophic reactions, I think we all would agree are clearly behaviors. Hoarding, well, yes, maybe if they're home, they have newspapers piled 6 feet high that could come crashing down on them as they try to go through these little paths they created. Yes, that certainly is a behavior. Inappropriate voiding, sexual disinhibition, again, I think we all would agree represents behaviors. And the one thing that I always like to point out in our training seminars is to ask the question, is the behavior being care planned? If you're taking that participant and putting them in a more quiet room, secluded room, because out in the day center where it's noisy, they're having a lot of these behaviors, then clearly that behavior as being care planned and is clearly can be coded as such. Or once again, though we try to stay away from a lot of the neuroleptic medication. If we are treating someone with Haldol or Risperdal, something of that sort, we want to keep that in mind that if you're treating it, they have it, and if not, please get them off that medication. Next slide. All right, let's switch gears now and talk for just a minute about depression. Again, DSM-5 is out, but here, fortunately, the criteria for major depression in DSM-5 is literally the same as what it was in DSM-4. And the only difference is I understand they're talking about having some criteria dealing with anxiety mixed in. I'm not sure that's been done yet. But if we look at these criteria for major depression, these are pretty much the same as what was described in DSM-4. The initial point we always try to instruct our clients about was to use the word major depression if indeed that's what the participant had, and to avoid the word depression. And usually, I think most of the time when we talk or use the word depression, what we're really talking about is major depression. And I'm not going to read down the slide for you, but if you read down that slide and a person has or participant has 5 of those criteria, that represents major depression. And we want to make sure we use that language. Very, very important. Once again, in ICD-9, the word depression would not risk adjust with Medicare Part A and B. It did for Part D, but not for A and B. Major depression risk adjusts for both A and B and D. So that was, when we talked in terms of ICD-9, that was a really important point to make. Next slide. So once again, just again to further show you the criteria for major depression with DSM-5, and you can read down that list yourself. I only would draw your attention to the last bullet point, and that is that if you're having recurrent depression, that means that the recurrence occurred at least 2 months after the remission began. Otherwise, you have a continuation of a single depression. So there's single episode depression and there's recurrent depression, and there's a criteria you can use to help you distinguish. Next slide. So when we go to document in depression, again, as I mentioned, don't just use the word depression. We want you to use the word major depression because that's probably what you're really saying is wrong with your participant. However, here we are in ICD-10. We have to go and take this another step. Simply saying now major depression, single episode in ICD-10 is not going to get it risk adjusted. If we now use just simply major depression, it codes to F32.9, and you can see what it codes along with: depression, depressive disorder, and major depressive disorder, NOS. So in order for these to map to the appropriate HCCs, we need to now use additional adjectives to define the severity or the presence of remission. Next slide. So here we are in ICD-10. This is the language that I'd like you to use from now on. If it was a single episode, which is what we're seeing on this slide, I want you to use a single episode, but then put some modifiers on it as well. So it's now major depression or major depressive disorder, mild, moderate, or severe, and if it's severe, is it with or without psychotic features? Or talk to me about, or talk to the coders about whether it's in remission. Is it in a partial remission or full remission? If you use that kind of language, it will code to those F32 codes that you see marked, and those all risk adjust. If you don't, and you use major depressive disorder single episode unspecified, you can see that's that F32.9, and that will not risk adjust. And once again, you'll be missing out on important revenue that you need to care for these very sick folks. Next slide. And once again, if it is a recurrent episode, once again, instead of F32, we now move up to F33. And you can see, by and large, again, it's the same terminology: mild, moderate, severe. The severe is with or without psychotic features, and then some specificity about the remission. But don't tell me why or how. I certainly don't know. Maybe Angie can weigh in on this. I have no idea why, in this situation, F33.9, which is major depressive disorder recurrent that's unspecified, that does risk adjust. Whereas if it's a single episode, it does not. Don't know the reason for that. But what I think a better way to look at it is to start understanding that with all of ICD-10, we need more description. So don't think in terms of, well, is it a single episode or is it recurrent? Which one do I want to remember, risk adjust or not? I think it's better to start thinking, I need to, when I document on depression, mark down whether it's mild, moderate, severe, whether it's in remission, put some other adjectives there for the coders to more accurately code for you. Next slide. So once again, just to take home points, documenting major depression requires a higher degree of specificity in ICD-10. Use the adjectives that I described for you, and keep in mind that if you simply just use major depression as we used to teach with ICD-9, that is not going to risk adjust. And if indeed a person is having major depressive disorder and you don't use the right terminology, then once again, that's one less HCC your participants are going to have. And I think I'm going to turn this back over to Angie. The next slide.
Yes, you are.
Yeah.
All right, everyone. That is the end of Webinar 5. And we all at Capstone want to thank you all very, very much for joining us in this ICD-10 documentation and coding webinar series. Again, you will receive a survey by email. And if you have any questions that we may or may not get to today, please feel free to email them to Dr. Shamp at the email listed there, or myself, and my email is listed there as well. So at this time, if anyone has any questions, we are happy to take any questions regarding today's webinar, or really any of the others if you so desire. Any questions today?
Angie, I didn't realize we were that complete in our descriptions. That's pretty good.
We must be. We must be. And you know what I'm wondering too, Mike, if major depressive disorder recurrent is an HCC because of the recurrent status.
Mm-hmm. And you're probably right.
Yeah, just because of the fact if you look, I don't know what monopolar depression is, but I'm just wondering if it has anything to do with the recurrence.
And you're probably right. You're probably right. And unipolar, just to distinguish it as being bipolar or depression that's associated with someone who has bipolar disorder. That's what they mean by unipolar.
Right. Right. And then just anybody who's on, you can look at all the I-69 categories, sequela, cerebral respiratory. It's pretty extensive. A lot more extensive than the 438 category. All right. Let's see. I'll get to the. It's so extensive I can't even find the late effective stroke code. There we go. Yeah. So it's very similar. I can't believe I didn't have a question from my friend in Pittsburgh, who is very close in proximity to where I live. He has a question for me every time, and he didn't today. Well, here we go. Hello.
Hello.
Hello?
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 Hi, can you hear me?
Yep.
Yes, we can.
Yeah, this is me.
Hi. I was wondering where you were.
Yeah, I didn't think. Well, let me say that one of the major aspects of the ICD-10 that it's confusing is the depression part of it. And
Okay.
not that you're, I mean, the explanation is understandable as far as, that and we've already told the providers to be more specific as much as possible. But as you know, sometimes, the only thing you can really document is just plain old depression. Is that something you encounter a lot? That sometimes you don't know how to characterize it, right?
Yes, and I think most of the argument is that the providers, they're coming to you with the diagnosis already. So if they're on treatment, you have no idea how much of a depression, they have. Did they ever meet the criteria? And what we usually suggest in that case is to just ask them or the family members, ask them what prompted, the need for you to be on antidepressants or depressants rather, or what happens when you go off of your medication, and even in their history too, and that would probably be able to give the providers a better clue, as to maybe. I think it's whether they feel confident making a diagnosis of major depressive disorder. For some reason, the word major scares them.
Yeah, and once again, this goes back to 40 years ago, 50 years ago, where all psychiatric illnesses are either lumped into what we call neuroses or psychoses, and what we call depression was put in the psychoses bin and called major depression because, indeed, in severe forms, you get psychotic features. And I would also argue that if, indeed, someone has committed suicide, attempted suicide, they had a psychotic moment there as well. So that went into that bucket. What was over in the other bucket was cyclothymia. It would be maybe grief reaction, or what we would call reactive depression. The dog died, the wife left me, I lost my job. Those kind of things where people get depressed, that would be just while that person's depressed. But when we talk about the real illness, most of the time we're talking about major depression. And I would also add that if the participant is on medication for depression, again, if you're not really believing that it's major depression, then once again, why don't you wean them off the medicine at that point? But if you're going to continue the medicine, I think you're to some degree ex post facto making a diagnosis that they actually have major depression.
I mean, I think especially in geriatric population, that makes a lot of sense. The fact that the one thing that I don't like, I think the fact that what they've done a couple of different times, they've taken away the optional part of the coding. Like, for instance, major depression. In ICD-9, you can have major depression, single episode, or unspecified. You can have depressive disorder, unspecified, or major depression, unspecified. But they've kind of taken away the unspecified element of it, so that, for instance, 90% of the time, it's documented as MDD, major depressive disorder.
Right.
So that, as you say, that's not going to work. I mean, the F32.9, is not what we want to capture here when, most of the time, obviously, putting a lot of resources.
It's not an HCC in ICD-10. So that's where you have to add your mild, moderate, or severe because, we've preached for so long that, if, call it major if it's major, but now we have to say, okay, we have to call it major and you have to say, you have to quantify it, mild, moderate, severe, for the HCC. So, I mean, I just think, I think as ICD-10 just gets into, as we get into it, I think that we'll start seeing this just because of the basic fact that the coders are just going to be, okay, well, is it mild? Is it moderate? I mean, yes, you do have unspecified codes, but, we're trying to get away from the unspecified. We're trying to get the providers to document specifics just because there's so much. There's just so much.
It makes a lot of sense. Thanks again.
Yeah. Sure. Do we have any other questions today? Oh, wait. What's Dr. Pillay is asking me something. You can't hear me, but if I don't have an actual diagnosis, I'm going to read you a question. It says, if I don't have an actual diagnosis for CVA and we don't do a CT because the patient is on a palliative path, how would we code a new CVA? I would say, Mike, do you want to take that?
Say that again, Angie. I'm not quite sure I understand the question. If someone has just some residual or what?
So I put it on the screen. Can you see the question?
No, I'm sorry.
Okay. So it says if you don't have an actual diagnosis for CVA and they don't do a CT scan because the patient is palliative, then how would they code for a new CVA? So in other words, what she's asking basically is, it seems to me that, because if you don't have a CT, can you still say CVA?
Well, you really can. Again, maybe it's fact I'm just getting to be a lot older, but I actually remember the days that we actually made the diagnosis of stroke before there were CT scanners. So you can still do that. And I would just remind every provider who's on the call that you have a diploma and you also have a license that you have on your wall that says you have the right, as Dick Shamp would say, to make a diagnosis. And once again, from a coding perspective, if someone has a sudden onset of right upper extremity weakness, and you believe as a provider that that's a CVA, and you document the weakness, the fact that it was sudden, and what you're going to do about that, then from a coding perspective, that person has had a CVA. We may be able to come in and argue with that from a neurologic perspective, but from a coding perspective, you have that right. And once again, I would suggest that most of the time, CVAs may actually confirm what I think you already knew. I mean, someone who has a slow progressive weakness over a month and a half or 2 months, yes, that wasn't a CVA. Maybe they have some other space-occupying lesion in their brain. You wouldn't call that. But a sudden onset of a neurologic event in our PACE population, chances are that's going to be CVA. And once again, the fact that you have good documentation as to what happened and what you're going to do about that, you have every right to make that diagnosis that's a CVA.
And she has an additional question. It says, if the patient presents clinically, how do we decide if it's ischemic, infarct, or bleed based on the fact that, ICD-10 is telling you we need to say what causes it? But I still think that there is, let me look down here. Do we have an unspecified? Oh, goodness.
I believe there's probably going to be an unspecified code there as well.
Unspecified post-cerebral artery. I think if you can, well, I don't know that you're necessarily, okay, yes, here it is right here. Cerebral infarction, unspecified. Stroke, not otherwise specified. Not otherwise specified. I-63.9 is basically for an acute cerebral infarction, unspecified.
Right.
So if you don't have the CT, then you could, that's essentially what it would be coded. You would state that the patient had, a CVA or a cerebral infarction, and that's all you know. So we can use the code I-63.9.
Yeah.
Does it map to an HCC? It should. Let me look. You're going to see my desktop here for a second. Desktop. I move that just because. Let me look here. I-63.9. I-63.9 does map to HCC 100. So I'm assuming it would be the same. It probably backwards maps to 434.91. That would be my assumption.
Mm-hmm.
Let's find out. 9. Yep. So yes, it's a, you're welcome. I'm reading her comments. Okay, so hopefully that maybe helps for some other people too. You can diagnose a stroke if you are based on clinical symptoms because you're a provider and you take that.
Yeah. Right.
Okay. Anybody else have any other questions? We have a few minutes left. If not, we will end for today. And if you should have any questions further regarding this webinar or any other webinar, please feel free to email me. You can email Dr. Sham. You can email Dr. Brett, and we'll be happy to answer any questions.
Thank you all for taking time and joining with us. We appreciate your attendance.
Yes, thank you very much. I hope you all have a wonderful afternoon, and pretty soon we'll be ICD-10. Thank you all for listening. Bye-bye.
Bye now.